So just to go over the first data system, I'm sure everyone's familiar with this. This is the Surveillance Epidemiology and End Results Program. So the CEER collects cancer incidence data and survival data from population cancer registries that cover about 28% of the US population. So it really gives you a broad overview of the US in terms of colon cancer incidence, mortality. So some of the variables that are included in CEER include primary tumor site, tumor morphology, stage, treatment, et cetera. And the CEER registries are generally funded by the NCI and/or the CDC. So this is just a map of the CEER states and regions that are participating in the CEER program. So you can see Louisiana here. This arrow is showing up there. Okay. So the Louisiana registry, so I'm based in Louisiana, is actually funded by both the NCI and the CDC, and you can see other regions are funded by, maybe funded by the NCI alone. But the bottom line is that the CEER covers 28% of the US population. CDC comparative effectiveness research data is the second data system that I'm going to talk about. This is kind of more detailed information that's normally in CEER data, so it's not typically collected by state registries. And this data was focused in 2011. So it includes things like tumor markers, like microsatellite instability, which is obviously very important for Lynch syndrome, KRAS, treatment regimens, even things like smoking, body mass index. So it's actually a really powerful data collection system that could really allow you to understand population-based analyses in the United States. And there are only 10 states participating in the CER data collection system, and I was lucky enough to be in Louisiana, which is actually one of those states. So the research questions I have regarding CEER, so I'm going to focus on the CER later on, but the research questions for CEER is how could CEER incidence data be used to identify areas in the US with disproportionately higher rates of colorectal cancer? So this is a pretty simple question. And to kind of follow through on this, you have to have a hypothesis based on regional clustering of risk factors or perhaps heritage that will allow you to use the CEER registry to kind of hone in on an area and try and correlate your hypothesis with increased colorectal cancer incidence rates. And then you could look for cancer clustering based on hypothesis. So just theoretically, if you're saying that there are more obese patients in the Pacific North, I'm just completely making this up, more obese patients in the Pacific Northwest, then you could use the CEER incidence data and see, if higher rates of colorectal cancer in that area. That doesn't prove that there's an association, but it could be a kind of a leadway to further study. So the way I use this is I looked at the Acadian region of southern Louisiana, which has a population of 1.2 million and is importantly the home of about 700,000 Cajuns. The Cajun population was established in the 1700s when French settlers or Acadians left Nova Scotia and they came to southern Louisiana mainly. And the interesting thing about the Cajun population is that they have compared to other US populations, they have strong geographic ties to a specific region. They maintained a distinct community, and they have a preserved language, which is Cajun French. So this is just a map of Louisiana, and you can see here that this is the Acadiana region in southern Louisiana, so it does not include New Orleans. And the critical thing about the Cajun population is that it's a founder population. So a founder population occurs due to a founder effect, so what happens is when you have a new population that originates from a larger original population, you could get decreased genetic variation in the new population. So in this example, we have French settlers from Nova Scotia, the larger population, at least in the 1700s, leading to a smaller settler population in southern Louisiana, which is now the founder population. So the Cajun population is actually the largest regional founder population in the United States, but no one has ever looked at cancer incidence in this population. So if a mutation associated with disease is introduced into a founder population, you could see very high rates of that disease within that population. So in the Cajun population specifically, there has already been a demonstrated founder effect for Tay-Sachs, oculopharyngeal muscular dystrophy, and some other autosomal recessive diseases. But no one ever looked at cancers that may be inherited in a Mendelian fashion, like colorectal cancer. So one way to look at a founder population is like a magnifying glass for the study of genetic diseases, because you may be able to find mutations that are present in other populations, but just will never be seen due to heterogeneity. So there may be similar, if there are mutations in the Cajun populations, that may be present on the east coast of the United States, for example, but you're not looking for it, so you may not see it. So you really need to kind of focus in on these founder populations because they're really a wealth of genetic information. So a good example of a founder population is Newfoundland, Canada, which has amongst the highest colorectal cancer rates in the world, and they have very high rates of Lynch syndrome there. Another example is actually breast cancer in the Bahamas, and BRCA is responsible for 23% of breast cancer cases in the Bahamas. So it just shows you how a Mendelian inherited cancer could permeate a population and lead to overall high rates of a cancer in a population. So it's important to study these founder populations. By the way, Newfoundland is in contrast to Nova Scotia, so the Acadians came from Nova Scotia, not Newfoundland. So in terms of our study, so we did an epidemiologic study, and the hypothesis, which follows from what I've already said, is that given the establishment of the Cajuns as a founder population, we want to determine whether colon cancer rates are higher in that region compared to statewide and US rates, because this could potentially imply an increased frequency of hereditary colorectal cancer because it is a founder population. So we used CEER data, publicly available data, so we had a hypothesis and we were able to use this publicly available data to try and answer that question, or at least create some information that will lead to further study to solidify the answer to that question. So what we did is we used French language census data from the year 2000 to identify 18 parishes in southern Louisiana with high rates of French speakers, and we also correlated that with ancestry data. And then we looked at a subpopulation with much higher rates of French ancestry and French speakers. And then we simply looked at colorectal cancer rates in that 9-parish region, the 18-parish region, Louisiana, and the US, and we wanted to see what would happen. And we stratified by race and gender. So this is a map, another map of southern Louisiana showing French language in the year 2000. And you could see that in some of these parishes, for example, St. Martin Parish here, 28% of the population actually spoke French in 2000. And probably in the 50s and 60s, it was much higher than that. It may have been 50 or 60% of the population speaking French. So you really have a very clear, defined population of French background in this area. So the bottom line is that when we did this study, we found that in the highest, in the Acadian 9, the highly concentrated French area, colorectal cancer rates were 13% higher than Louisiana and 23% higher than the US. And and that was in whites. And then in white males, it was 19% higher than Louisiana and 37% higher than the US. We found very, very high rates of colorectal cancer in this region. And Louisiana already has the 3rd highest rate of colorectal cancer in the United States, so this 20% increase was statistically significant and obviously of public health concern. So now this is an early onset colorectal cancer symposium, so we also looked at rates in patients under 50, and what we saw was a very strong trend. I'm gonna show that slide afterwards, but so this is the data that was published, and you can see here that in white males and females, going from national to Louisiana to the Acadian 18 to the Acadian 9, you can see this stepwise increase in colorectal cancer rates, and it's very dramatic for white males, less so for white females. Now, African Americans have very high rates of colorectal cancer in that region as well, but the rates didn't increase in this stepwise fashion. So this is the interesting slide. So this is the colorectal cancer rates in patients age 40 to 49. And you can see here that in white males and females, the incidence rate was 31.3 per 100,000 compared to 21.5 per 100,000 in the US CEER population. So it's a lot higher and statistically significant. There's also a nice trend going up, and you can see the p-values kind of increasing here. And probably the numbers are too small to demonstrate statistical significance, but there probably is a true trend here, where you go from US CEER to Louisiana to the Acadian 18 and to the Acadian 9, showing these very, very high rates. And it's similar in white males. You can see this very, very high rate of 34 per 100,000 for white men age 40 to 49 in this region. You know, keep in mind, this is a fairly big region, 1.2 million people. And in white females, you can see that it's also very high, and it just missed statistical significance here. And then we also looked at the under age 50 group, and same kind of a pattern. So in white males, it was 10 per 100,000 per year compared to 6.6 for US. So very, very high rates of early onset colorectal cancer in this region. Interestingly, if the Acadian 9 were considered a state, white males, any age white males, would have the highest rate of colorectal cancer in the United States by 11% compared with other white male populations. And that other, the leading state would be Kentucky. So this study, just by using CEER data, publicly available data, and having a hypothesis, we were basically able to identify the highest rate of colorectal cancer in white males in the United States, and we found out that there's a very strong trend of increased rates of early onset colorectal cancer in this population. So this is just a slide showing the rates of 73 per 100,000 in white males compared to the United States and all the highest ranking states, and these are all statistically significant. So white males, highest rate in the United States. So what about other cancers like non-colorectal cancer? Because other cancers sharing environmental risk factors with colorectal cancer, like breast, lung, pancreatic cancer, they were actually not disproportionately higher. So it's really only colorectal cancer that was disproportionately higher. So this really argues against a shared environmental risk factor as an etiology for the high colorectal cancer rates in the Acadian region. And our leading hypothesis is that there may be a founder effect for Lynch, but we're going to have to figure that out. We have grant funding to figure that out now. We also looked at smoking, obesity, health insurance, et cetera, and there's really no difference in those variables in the Acadian region compared to other parts of Louisiana. This is interesting. So this is a slide about northern Maine. So northern Maine, Aroostook County specifically, has the highest regional percentage of French speakers in the United States outside of Louisiana. And this is the same population. So when people left Nova Scotia, they went to northern Maine and southern Louisiana. So this genetically similar population. And they actually have Acadian culture. I don't know if anyone's ever been there, but there's an Acadian culture, very similar to southern Louisiana, but very, very different environmental exposures there. So if you look at actually the CEER data, I'm just going to show you the map first up here. Colorectal cancer in that county in whites is 27% higher than statewide rates in whites, and 31% higher in white males compared to the rest of the state of Maine, and much higher than US rates as well. So it's the same exact pattern, which is very interesting because these populations have been separated by over 1,000 miles for 300 years, yet they share the same genetic ancestry, not completely the same genetic ancestry, but there's definitely some similarities. So it's actually very interesting and another example of how you could use CEER data to answer a hypothesis or to address a hypothesis. So here again, you can see these high rates up here in northern Maine. So the conclusions from this study is there's obviously something unique about the white population, and particularly the white male population in the Acadian parishes where French is more frequently spoken and where sometimes in some of these parishes 70% of the population claims to have French ancestry. There's obviously a very, very concerning trend of early onset colorectal cancer in this region. And as this is a known founder population, we're looking, our hypothesis is there may be a founder effect for Lynch or something else. So that's kind of what we're going on. We actually have, as I mentioned before, we have grant support. We have about 65 to 70 Cajun patients that are under age 50 in Lafayette Hospital, which is in the center of Cajun country, and as we speak, we're doing microsatellite instability testing to look for a signal for Lynch. That's not going to prove anything because it's only 65 patients, but if there's a strong signal there, we're hoping to get a larger grant to really kind of blanket that region and look not only for hereditary, but perhaps there's some kind of odd focused environmental risk factor that's disproportionately affecting whites and white males in that population. So it's very interesting. So now I'm just going to switch gears. That was the bulk of my talk, but I'm going to switch gears. I am going to talk a little bit about Lynch syndrome and comparative effectiveness research data, so focus in on Lynch syndrome management using registry data to see how we're managing Lynch syndrome. So Lynch syndrome accounts for about 3 to 5% of colorectal cancer, and in patients less than 50, it could be up to 17%. I know that other people in other slides have said it's about 10%. There's one paper where patients were not selected for family history. It was a fairly small number of patients, but it was around 15, 16, 17%. So that may be a bit on the high side, but it may range up to that. So it's autosomal dominant with 80% lifetime risk of colorectal cancer, and as we all know, it's critical to screen for Lynch because of the high risk of colorectal cancer, other cancers, and for family members. So Lynch syndrome is associated with mutations in mismatch repair genes, MLH1, MSH2, MSH6, and PMS2. And that leads to microsatellite instability and deficient corresponding MMR proteins on immunohistochemical staining. The reason I'm even mentioning this is because we had, in our study, we looked at MSI and IHC testing in young patients with colorectal cancer, so I had to give a little background on that. So the bottom line is when you have a colorectal cancer, you want to do microsatellite instability testing and or IHC testing in order to screen patients for Lynch syndrome. And then if that's abnormal, you're going to do germline genetic testing to look for a tree mutation. And sometimes even if a person doesn't have colorectal cancer, but they have a strong family history, you may be doing germline testing anyway. So what we did is we used this detailed comparative effectiveness research data to assess Lynch syndrome management in early onset colorectal cancer. So we wanted to see how effectively are we screening young patients for Lynch. And unfortunately, there are really no population-based studies on this. There are lots of guidelines saying, oh, you know, well now there's call for universal testing where everyone gets screened. But when the study took place a few years back, this was from 2011, we decided to look at patients that were under 50 because those are the highest risk patients, and 100% of them should get tested. And no one really knows what's going on in the United States with Lynch syndrome screening, like how effectively we're doing it. So as I mentioned, we looked at all patients 50 and under who are the highest risk for Lynch, and we had 274 patients, so we were able to look at literally every single patient in our state with colorectal cancer at every single healthcare facility. So it was a true population-based study just showing the power of CDC CER data. So this represented care at 61 healthcare facilities, so there you're kind of eliminating bias, right? If you look at one healthcare system, they may have a universal screening protocol in place, whereas other hospitals may not. So if you only look at one hospital system, you may get results that don't reflect what's really going on in the community. And as I mentioned, the Lynch syndrome screening rate with MSI and/or IHC should be 100%. And so I'm sorry the slide did not come out very well, but what we found is very concerning. We found that in patients under 50, early onset colorectal cancer, only 23% of people were getting screened for Lynch syndrome. And this is not that long ago, this is 2011. We published this last year. And then here you could see, we did multivariate analysis, and you could see that in rural areas, the rates were dismal, 12.3%, compared to 25.9% in urban areas, which isn't that much better. If there was a first-degree relative with colorectal cancer, the rate actually went up to 48%, but that's still really low. I mean, if you have someone who's in their 40s with colorectal cancer and they have a first-degree relative, I mean, you should be tested. I mean, that should be a slam dunk that you should be doing the testing. But even in that case, only 48% of people are getting tested. And in public hospitals, 6.5% of people are getting tested. I think there was like one person that got tested. So absolutely terrible screening rates for Lynch syndrome. So the other thing, this isn't on the slide, but the other thing we looked at, just to be brief, is that we wanted to look at the timing of Lynch syndrome testing because we wanted to see if the results are available for the surgeon to make sure that because the results could be used to plan the operation, a more extensive colonic resection. And we found that only 17% of the time were the results actually available preoperatively. So most of the time, these results were coming back after the surgery already took place. So there was no opportunity for the surgeon to have a risk-benefit discussion with the patient. So there are a lot of factors involved in this. Most of the time, the GI doctors were not doing the testing on the colonoscopy. The surgeons were actually doing it. And a lot of times when it was done on the colonoscopy, it was taking weeks for the results to come back. So the patients would go to the OR for a variety of different reasons, and the results would return afterwards. And it was too late to have that risk-benefit discussion with regard to extent of colonic resection. So that was another key finding of our study, and really a call for making sure that we have a streamlined process in place with MSI, IHC testing, germline testing, and hopefully these results available so the surgeon could have a rational conversation with the patient. So just to conclude, tumor registries are an important source of population-based data that could obviously allow us to better understand colon cancer, and in this case, even early onset colorectal cancer. CEER data could provide descriptive information on cancer in regions. It's not going to tell you cause and effect, but it could be a lead off to other studies like our grant now, which we got because of the CEER data analysis. And the CER data is very powerful, and it really allows you to see how patients are managed. And that's it. Thank you.